So I have the same conflict of interest as yesterday, so I'm not the king, but the jester of ultrasound here. So the thing is, when you think about uterus as a forgiving organ, if you think, oh, what we do to the uterus, and we do myomectomies, we do cesarean sections, scar repairs, and eventually they become pregnant. And that's quite amazing, I think. So, but having said that, yes, how do we describe the niche, the cesarean scar defect on ultrasound? So we published together with the group of Judith Hearn in Amsterdam a paper on how to do that. I will not go into details about that. You can just scan the QR code, but I'll show you some examples of a niche at ultrasound, and that's quite a big niche here. You see the cavity here, and here you see, I mean, there is no myometrium left. So I think, well, is it important? Well, my gut feeling says yes. Here you have another one. Sometimes it's not so easy to diagnose that, and sometimes even you don't see the niche, and that's why I think it's important. If you want to see if there is a niche, you have to, and you don't see it immediately because there is fluid inside, just do some fluid instillation, and often you will see that indeed there is a niche because it's just the two walls who were against each other. But with hydrosonography, we can see it quite easily. And that's another case of a very easy to see niche, a massive niche here. We see the fundus is here, the cavity is here, the cervix here, and then this hole is a niche. And I think, well, this is probably very important to know that before engaging in pregnancy. Okay, when we see a niche, well, we have to describe it, and it's easy to describe a simple niche, just a triangular niche. That's quite simple. We report the length of the niche here from there to there, and but sometimes the niche is more complex, and sometimes very complex with cystic areas and so on. Then it's harder to describe, and it's important to also to have iconography, to take pictures to show to the surgeon what you saw, or the surgeon or the fertility specialist or so on. Sometimes, I mean, the entrance is not that long, but you have it widens in the middle of the defect. That's possible. You also have the depth of the niche. The depth of the niche is from the cavity line here up to the top of the niche, and indeed it's easy if it's nicely triangular. If it's a more complex niche, it's more difficult, but try to report it as precise as possible and take pictures, and I would say also use 3D to have a better overview of the problem. And then the third measurement is the width of the niche. Again, that's the width in transverse section, and that's easy in a simple niche. If you have a more complex niche, you should measure the width at the base, but also the width where it's at its largest, and describe what you see, and take pictures to show your colleagues. A very important measurement, we think, is the residual myometrial thickness. In fact, is the myometrium just overlying the niche, to say, is there still something to hold the niche together? And that's the residual myometrial thickness. And this is, in fact, yes, you see the myometrium. How much myometrium is there still left above the niche? And sometimes it's also complex because you have also an invagination from the outside. You have some fibrosis and scar tissue, and the thing is, well, just describe what you see. We don't know how is it an advantage, is it a disadvantage to have this scar tissue? But you have to describe it, and usually the RMT is used as one of the most important parameters in the management of the niche. Now, when you have a scar defect, well, obviously we think if you have a crack in the wall, there is a danger of collapse, and then you can say, well, if there is a hole, then obviously there is a danger of rupture. But if you ask the people from physics, they say that's not that simple. It's not because there is a hole that it will rupture. I mean, if you have a hammock, there are holes, but here the lady here, who is for a physician, it's the stress. She can lay on the hammock without rupture. So it's more complicated than that, because you need to know, and that's something we don't know. What's the quality of the tissue and how strong is the tissue of the overlying tissue? Okay. Now the thing is, what we know about niches is that it's associated with abnormal bleeding, dysmenorrhea, infertility. That's something we know. About uterine rupture, risk of malplacentation, cesarean scar pregnancy, that's something that's, that needs more research, because that's not so easy to do research on. We know, well, there is a lot of research, and especially in the group of Judith Turner, who did some, and of Olivier Audonné, of course, who did research on laparoscopic resection, and indeed it's proven that if you do a repair of a resection, that the bleeding, dysmenorrhea, and so on will be better after the surgery. About the fertility, we know that the pregnancy figures are quite good, but I think what's important in the counseling in the patient with the cesarean section is she will ask about rupture. That's not so common. That's why a study is difficult. It's about 2 in 1,000 who will have a rupture. Of course, if you put it in relative risk, it's more dramatic. It's a relative risk of 25 compared with 100 for myomectomy, 250 with adenomyosis surgery. That looks, but in absolute figures, after cesarean section is 0.2%. That makes it difficult to study, but it's important to give information to your patient about that without making a drama of it. But I think what's even more important and less studied is in fact the cesarean scar pregnancy and the malplacentation. I think the most important information for a woman with a scar defect is to tell her, if she's pregnant, that she comes early in pregnancy, that we can see where the pregnancy is, and to rule out a cesarean scar pregnancy. I think that's, in fact, the main message you have to give. And let's say, not forget, but about the rupture, but cesarean scar pregnancy. If you have a real cesarean scar pregnancy, it's better to see it very early on in the pregnancy, then you can do something about it without any risk and of course, what is the thing we have to avoid is the placenta accreta spectrum, the malplacentation, because that's really big, dangerous situations. I'm involved in the placenta accreta team in Leuven, and I can tell you, if it starts bleeding, it bleeds a lot, and it's something you have to, if you can avoid it, you should do it. And that's why it's important to give the information to the patient about that, to say why it's important to come early in pregnancy, if she's pregnant, to see that and to well, kind of prevent these kind of situations. So to conclude, well, there is a lot we don't know, and if I don't know, I will not pretend I know it. And okay, thank you very much for your attention.